Hello, I'm Dr. Roger Henderson, I'm a GP, and I also co-host the GP Notebook study groups. Welcome to the GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. Now, in this episode, I'll be discussing intermittent claudication, one of the most important clinical flags for peripheral arterial disease, or PAD. And straight off the bat here, if you remember only one thing from this podcast, it should be this. Intermittent claudication is more than just leg pain. It's a sign that the patient's entire vascular system is compromised, and more often than not, the most serious threat to the patient's health isn't their leg, it's their heart and brain. Now, the word claudication comes from the Latin claudicare, meaning to limp, and the intermittent part reflects the stop-start nature of the patient's discomfort. So they walk, the pain starts after a certain distance, they stop for a minute or two, the pain melts away, and they can start walking again. And that's so characteristic that when present, it's almost diagnostic, although, as I'll discuss later, there are a few conditions that can mimic it. Now, why does it happen? Well, the simplest way to understand this is to think about the balance between oxygen supply and demand in skeletal muscle. So at rest, a narrowed artery can still deliver enough oxygen because the muscle's needs are low. But during exercise, such as brisk walking, climbing a hill, or even just shopping, the muscles suddenly demand several times more oxygen. Now in healthy arteries, this isn't a problem. They dilate, blood flow increases, and supply meets demand. But in a limb with atherosclerotic narrowing, the supply can't increase enough no matter how much the downstream arterioles try to open up. And that's the flow limitation problem. Now, once demand outstrips supply, the muscle shifts into anaerobic metabolism, producing lactate, hydrogen ions, adenosine, and potassium, all of which irritate sensory nerve endings in the muscle and send a pain signal to the brain. It's a chemical warning light, if you will, to the patient, basically saying we're starved of oxygen. Now, a very important point here, and one that can be very useful clinically to all of us, is that the location of the pain depends on where the narrowing is. So if the blockage is high up in the aortoiliac segment, for example, the patient may feel pain in their buttocks, hips, or thighs. If it's in the common femoral artery, the pain is likely to be in the thigh, but sometimes extending to the calf. But the most common site of disease is the superficial femoral artery, and in that case, the pain is felt in the calf muscles. In rarer cases, if the disease is in the popliteal or tibial arteries, the pain may be confined to the lower calf or foot. Now, incidentally, from your medical student days, you may have heard of Leriche's syndrome, which is a special pattern of aortoiliac occlusion that causes bilateral buttock claudication, impotence, and absent femoral pulses. And René Leriche described it in the early 20th century, and his work was one of the foundations of vascular surgery. Now, looking at risk factors next, these are exactly the same as for coronary artery disease, because PAD is just a different manifestation of the same systemic process, atherosclerosis. And smoking is right at the top of the list here. In fact, I often say smoking is to PAD what hypertension is to stroke, the single most powerful modifiable risk factor. Smokers are far more likely to develop claudication, and they do so about 10 years earlier than non-smokers. Diabetes is next on the list, and this is a double whammy. It speeds up atherosclerosis, and it also damages the microcirculation. So even if you clear the large vessel, the small vessels may still not deliver enough oxygen. Then there's high cholesterol, particularly elevated LDL levels, high blood pressure, which damages the endothelium, and of course our old friend Age. The older the patient, the greater the risk. Men are affected more often than women, although this gap does narrow after the menopause. When we take a history from a patient with PID, our job is to confirm that the pain fits the classic pattern. So we want to know exactly what it feels like, where it is, how far they can walk before it starts, how quickly it goes away when they stop, and what activities bring it on. And one question I've learned to ask over the years is whether they ever have to stop when out shopping and look into a shop window just to give themselves time for their pain to ease off. And this question hits pay dirt more times than you might imagine. Always ask if it ever occurs at rest, particularly at night when lying flat, as that could mean they're starting to develop critical limb ischemia. And don't forget to ask about symptoms from other vascular territories: chest pain, shortness of breath, transient vision loss, weakness or numbness in the face or limbs, because PAD rarely occurs in isolation. Going on to examination next, look at the legs before you touch them. Is the skin thin, shiny or hairless? Are the toenails thickened and brittle? Are there ulcerations on the toes or heels? When you do palpate pulses, compare them on both sides: femoral, popliteal, posterior tibial and dorsalis pedis. Listen for bruits over the femoral artery and check capillary refill. You can also do Berger's test here. Elevate the leg and look for pallor, then lower it and watch for the dusky redness of dependent rubor, which reflects arteriolar dilation in response to ischemia. Now, going from the examination couch, we can then move to investigations, and the ankle brachial index is probably the simplest and most useful starting point here. You simply measure the systolic pressure at the ankle and divide it by the systolic pressure at the arm. So a normal ABI is between 1 and 1.3, with anything below 0.9 being considered abnormal, and the lower the number, the more severe the disease. Below 0.4 usually indicates severe ischemia. Now, sometimes the ABA is falsely high, above 1.3, and this is because the arteries are calcified and incompressible. And this is common in diabetics and patients with chronic kidney disease. And in those cases, you might consider using toe pressures or pulse volume recordings. Now, if the patient's symptoms sound very convincing to you, but their ABI is normal, you can arrange an exercise ABI, where the patient walks on a treadmill until they develop pain, then the measurement is repeated. And a significant drop in ABI after exercise confirms the diagnosis. Now, once you've established PAD, imaging is used if you're considering intervention, and duplex ultrasound is a good non-invasive option here to see where the narrowing is and how severe it is. If you're planning surgery or angioplasty, then CT or MR angiography will give you a detailed map of the arterial tree. Digital subtraction angiography is probably still the gold standard, but it's invasive and it's usually reserved for cases where you're going to treat at the same time. So let's talk management next. And the first step, and the one that has the biggest impact on survival, is addressing the cardiovascular risk factors. If the patient smokes, stopping is absolutely critical here. And I tell my patients that quitting smoking is the single most important thing they can do for their legs, their heart, and their brain. You can also treat their blood pressure, control their cholesterol, and optimize their diabetes management. And exercise therapy too isn't just helpful, it's a cornerstone of treatment. And we're talking about a structured program here, ideally supervised, where the patient walks until the pain starts, rests until it goes away, then walks again for about 30 to 45 minutes at least 3 times a week. And over time, this can significantly increase the distance they can walk without pain. And it works by improving muscle efficiency, encouraging collateral vessel growth, and possibly even improving endothelial function. Antiplatelet therapy, such as aspirin or clopidogrel, and high-intensity statin therapy are recommended for all patients with symptomatic PAD. And the use of low-dose rivaroxaban, a DOAC, compared with low-dose aspirin reduces ischemic events compared with the use of aspirin alone, and it's recommended as a treatment option for selected patients with symptomatic PAD, but this combination is associated with a higher risk of bleeding. There are medications specifically aimed at improving walking distance, and aftidrafuryl oxalate is recommended as an option in the NICE technology appraisal guidance for treating intermittent claudication in people with PAD, for whom vasodilator therapy is considered appropriate after taking into account other treatment options. Now, pentoxifillin and inositol nicotinate are not recommended for the treatment of intermittent claudication in people with PAD, but cilostazol has been shown to be a benefit in improving walking distance in people with intermittent claudication. And this is a phosphodiesterase 3 inhibitor with vasodilatory and antiplatelet properties, and it can increase pain-free walking distance by 40 to 60%. But it's not for everyone though, because it's contraindicated in heart failure. Now, if symptoms are really limiting despite optimal medical therapy, or if the disease is progressing towards critical limb ischemia, you can then consider revascularization. Endovascular options like balloon angioplasty, stenting, or atherectomy work well for certain lesions, especially shorter and more proximal ones. But for long segment disease, especially in the femoropopliteal region, then surgical bypass may be a better option here. And the choice depends on the anatomy of the disease, the patient's comorbidities, and their functional goals. So when everything else has been tried without success, that's when we typically start thinking seriously about revascularization. And when we talk about surgery here, we're actually talking about two broad families of intervention: endovascular and open surgical bypass. And these days the boundaries are often blurred because hybrid procedures combine both approaches. Now, NICE states that angioplasty should be offered when risk factor modification has been discussed, when supervised exercise has failed to improve symptoms, and when imaging shows angioplasty is suitable for the patient. Bypass surgery is the most common surgical approach for diffuse occlusive disease, and indications for surgical intervention in PAD include disabling claudication, critical limb ischemia, and obviously urgent referral is recommended there, or weak or absent femoral pulses. And many centres now favour an endovascular approach due to reduced morbidity and mortality, preserving the surgical option in case of failure. And there's currently no evidence for superiority of atherectomy over angioplasty on any outcome. Now, although symptoms are frequently unilateral, most people with claudication are found to have bilateral disease, and revascularizing one leg often unmasks previously asymptomatic disease in the other leg. But whatever method is chosen, revascularization isn't the end of the story, because the patient still needs aggressive medical management of their atherosclerosis. Even if you fix one segment, another can narrow down over time. They also need follow-up with duplex surveillance to detect restenosis early, when you can often fix it with a simple touch-up angioplasty rather than waiting for symptoms to return. And perhaps the most important take-home point: in intermittent claudication, you should never rush to surgery just because you can. The long-term functional benefit has to outweigh the risk, and conservative therapy should be given a full and genuine trial first. The best surgical outcomes happen when the patient is optimized. They're medically stable, they're well informed, and they're motivated to protect their new graft or stent by sticking to strict lifestyle changes. Now, the prognosis of intermittent claudication is interesting. Many patients remain stable for years, and with lifestyle changes, some may even improve. A smaller proportion will get worse over time, and only a very small fraction will lose their limb. But across the board, cardiovascular mortality is high. About 1 in 5 will have a major cardiovascular event within 5 years. So that's a quick overview of intermittent claudication in peripheral arterial disease, and I do hope you found the podcast helpful. But have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you consider following the podcast and leaving us a review on your favourite podcast platform. It really does help. Feel free to get in touch via social media at GPnotebook or email support@GPnotebook.com if you have any questions, comments, or ideas for future podcasts. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you for listening, and goodbye.